Hello out there. This is going to be a presentation about validation therapy. All right, we're here with a live studio audience because I tried to record this presentation at home and it did not go well. I think all my dreams of having a podcast are officially crushed. My name is Hannah Brown. I'm a recreation therapist at the Rochester Psych Center. And we're going to talk about validation therapy for people with dementia-related diseases. So let's get right into it. So a little bit about myself. I was thinking about what population I wanted to work with in college. And I feel like in college, everybody has like this big pie in the sky idea, like I'm going to work with kids, like at-risk youth, or like for recreation people, it's a lot of like, I'm going to work on a cruise ship and be the entertainment. And like people have these kind of fantastical ideas. And I remember having a professor who was like talking about how geriatrics is the biggest field for people in recreation. And I was like, that sounds terrible. I will never do that. But of course, there's a reason that those jobs are really available, and that's because there's tons and tons of older adults. So of course, like during college, I got a job in an assisted living. And then after college, I worked for the Alzheimer's Association. And then when I got hired here at the Psych Center, it was on the geriatric unit. So I've pretty much mainly been working with older adults for my entire career. And it's like probably one of the best things that's ever happened to me. So one of the most challenging things about working with older adults, though, is working with people with dementia-related diseases. It's extremely tear-inducing, sad. It can be really, really sad at times. Can be incredibly frustrating, but it can also be super, super rewarding. So as we talk more about this specific intervention for working with people with dementia-related diseases, let's think about the people that we have cared for with dementia. So what kind of programming have we done with them? What were the challenges involved with that programming? And what were those warm and fuzzy moments that made us want to come back? Because I can't speak for, everyone here in the room with me or everyone sitting at home on the couch, but like there have been many times working with people with dementia-related diseases where I had to go hide in the recreation closet and cry because I was so incredibly frustrated, with the perseverative questions or the behaviors, or just getting groped. I don't know if everyone's had the experience, but I've had it a lot. That's really challenging, but there's a reason that we keep coming back to it when you're in elder care. And let's take like a moment to just think about what are those reasons. So what is dementia itself, right? And if you ask an average person what the difference between Alzheimer's and dementia is, most people will not give you a clear answer. And you can't really fault anyone for that. It's just because there's not a lot of education about the topic. But we want to be sure that we're differentiating as we dive into this. So dementia is a descriptive term for a cluster of symptoms. So when we think about dementia, we're thinking about changes in personality and mood, changes in memory. All of those things are present in the dementia process. So this is a really cool little tree thing that my coworker Liz Marsh made. We worked at the Alzheimer's Association together. So she made this little tree to kind of explain the difference between a dementia-related disease and dementia itself as a cluster of symptoms. So you see up at the top of the tree, we have our fruits, right? So we have our memory, language, personality, thought, and behavior changes. But at the bottom of the tree, we have our roots. So these are things that are causing those dementia symptoms. So we have vascular dementia, Lewy body, Alzheimer's, frontotemporal, and then reversible dementias. Because there are a number of dementia-related diseases that are reversible, like, for example, B12 deficiency or even mood disorders. We see this a lot in behavioral health, but we don't always identify it as being a dementia-related disease, but depression can cause dementia. It can cause changes in memory. So there can be a number of different reasons. And when we look at somebody with a dementia-related disease, they don't always look sick. A lot of the time we associate a dementia-related disease with older adults, so they might look frail, but there isn't anything like glaringly physically wrong with them. And that's because ultimately all the changes that are happening to somebody with a dementia-related disease are kind of sourced at the brain. That being said, there are some changes to the eye cells and the ear cells, but mainly things are coming from the brain. This is our brain here. Oh, it looks so good. Squishy, happy, full. We love to see it. Okay, so what is our brain made out of? It's made out of like a bajillion cells. So on the left, at the top side of the screen, we have our immune-related cells, glial cells, performing all kinds of lovely, important functions in our brain. At the bottom, we have an illustration of a neuron. So you can see we have our body of the neuron, we have our nucleus in the middle, and then that long kind of branching structure is our axon. So everything that we're thinking, seeing, processing, doing, that's coming from chemical signals coming through the axon and then shooting out into that synaptic cleft into another cell. So you guys hearing this information, processing that, thinking this is boring, I can't wait until I get out of here and can finish my lunch, and then planning your next move, that's all coming from those chemical messages. So on the right-hand side, we have our beautiful neurons. They look so gorgeous. They're just floating around talking to each other right now, giving us all of our thoughts and personality. Wild. What a body we have. Okay, so here's our brain. So we kind of have this understanding that different parts of the brain control different functions. So our frontal lobe, it has our motor control, problem solving, speech production. It's also like all of our judgment, impulse control, reasoning. We see people with traumatic brain injuries or frontotemporal dementia. We're seeing a lot more of that impulse control issue related stuff. A lot of issues with having a filter. People might be saying things out of pocket. That's an official diagnosis. I don't know if you guys know that. Saying things out of pocket. Find it in the chart. We have our temporal lobe, so that's our auditory processing, and a lot of our language comprehension is coming from there. And then we have our memory and information retrieval, because our hippocampi structures are in the temporal lobe. So we talk about Alzheimer's. The temporal lobe is really important because that's where Alzheimer's disease actually starts. At the bottom, we got our brain stem. So that's our reptilian brain that is just really concerned with pooping and sex and all that other fun stuff. We have our cerebellum for balance and coordination. Shout out to the OTs in the room for getting people healthy with their cerebellum. We have our occipital lobe in the back, which is a lot of our visual interpretation and sight. And then our parietal lobe, which is a lot of our sensory processing and body orientation. Again, shout out to the OTs in there, yeah, for taking care of our parietal and our occipital lobes especially. So we talked a little bit about the different diseases causing dementia. Again, dementia being our cluster of symptoms. The most common one is Alzheimer's disease. So 60 to 80% of dementia-related diseases are caused by Alzheimer's disease. It's very, very common. It's getting more and more common all the time. As people are living longer and more older adults are aging up, we're seeing higher and higher cases of Alzheimer's disease. So it's fairly common. I think most people that we know either have had a loved one or have worked with somebody with Alzheimer's disease. We have our vascular and cerebrovascular dementia, and so that's caused by basically anything that's damaging blood vessels that are transporting blood, oxygen, and nutrients. So some common symptoms that we might see related to vascular or cerebrovascular dementia are decreased motor function, slower gait, poor balance. It's very common with strokes, but only 5 to 10% of people have vascular dementia alone. Oftentimes it's mixed with Alzheimer's disease, which is kind of interesting, and I don't know that it's exactly understood why that is. We have Lewy body disease, which can be really, really difficult. It's caused by clumps of protein in the cortex and the substantia nigra. So it's causing a lot of sleep disturbances, intense visual hallucinations, and visuospatial impairments. So some common things that you see with Lewy body disease are hallucinations of people, like shadow people, and that can be really scary for people. You'll also see pretty commonly people feeling like they're seeing and feeling snakes or bugs on them. And it's a very, very challenging disease because obviously it's very disturbing for people experiencing it. We have FTD, frontotemporal dementia, or frontotemporal lobar degeneration. used to be called Pick's disease, but now we just refer to it as FTD, and it's actually a number of different specific kinds of FTD. But basically, that's an increase in tau protein in our frontal and temporal lobes and cortex. And so some common things that we're seeing with that are changes in language and behavior. It typically has an earlier onset too, generally between ages 45 to 60 years old. So this can cause a lot of challenges for us in the healthcare field too, because it causes a lot of difficult behaviors. So if this is something you're interested in learning more about, check out my other presentation that my coworkers might be asked to sit through too. We'll see how that goes. To learn more a little bit about just the disease process with that and how to program for people with FTD. We also have dementia related to Parkinson's disease, which people used to think was just Lewy body disease, but now we know that they're two separate diseases. Hippocampus sclerosis, which is like a hardening of the hippocampus, and then again, mixed pathology, so a number of different diseases here on this list. So what's happening in the brain of somebody with Alzheimer's disease, right? So on the left, we have our healthy neurons, happy, healthy, talking to each other, just out there really living their lives and vibing, sending chemical messages. On the right, we have our plaques and tangles. So basically what's happening in the brain of somebody with Alzheimer's disease is they're getting these plaque buildups. So if we think about plaque on our teeth, it's made of bacteria. This is a protein, so it's a little bit different. The idea is generally the same. It's gook. It's just like some gooky buildup on the brain. So that's jamming up the cell's ability to communicate with each other or share nutrients. So we have this plaque buildup, and we're not really sure why it happens. There's a lot of research about that going on now. Some people say it's related to inflammation. Some people say it's just like a genetic expression gone haywire. We're not really sure. But the plaques are a hallmark characteristic. We also have our neurofibrillary tangles. So those are our cells that are basically misfunctioning and dying, and then they're clumping together. So they're no longer sending messages to other healthy cells. They're impeding in the communication and flow of those chemical messages. So both of these things together are like the two kind of hallmark characteristics of Alzheimer's specifically. So again, this is like an actual IRL look at what's going on in the brain. You see our plaques, gross, nasty. And then on the right, we see our tangles. So those are just kind of like shrivelly, sad-looking neurons. Pour one out for the cells that didn't make it. So what does that mean for the brain overall, right? On the left, we have our healthy brain, hefty. On the right, we have our brain of somebody with Alzheimer's, wimpy. So we have some different changes going on. You can see that the cortex is actually shrinking. So all of those wrinkles on the outside are getting sucked inward, and then the ventricles on the inside of the brain are widening. So what's effectively happening is that people's brains are wasting. They're dying. They're losing mass. The brain of somebody who dies with Alzheimer's disease is significantly lighter than the brain of somebody who dies without Alzheimer's disease because those cells are dying. That's really important to consider when we're talking about communication interventions and what are realistic goals for somebody with Alzheimer's disease and what are not realistic goals. So what does that mean for people's communication, right? So we have a number of different changes for people. Number one, we have like the anomia. This is probably one of the most like noticeable things. So anomia is that inability to find the right word. Right? So it's our inability to find the right word. So you'll see, and you know, we all experience this to a certain extent, but for somebody with Alzheimer's disease or a dementia-related disease, it's bad enough so that it's affecting their daily life. That's another important kind of side note, is that we all have some like age-related memory impairment, or in my case, recreation-related memory impairment. But what the difference is for somebody with Alzheimer's disease is that this is something that's impacting their quality of life and their ability to live independently, and it's progressive, so it's getting worse. So we have our aphasia, and that's our difficulty understanding and expressing language. So these are like language changes that are rooted in the brain. We have paraphasia, so that's like kind of just mixing up words. Perseveration is one of the most common things that you'll see with somebody with a dementia-related disease, and how that will manifest is usually like, when's lunch? And then you're like, lunch is at 12. And they're like, oh, okay. when's lunch? And you're like, lunch is at 12. And they're like, oh, okay. But then they're like, when's lunch? And you're like, oh my God, I told you it's at 12. Right, so it's perseveration. Their brain is just kind of looping back to that. Word salad, which might be my favorite medical term ever because it just is exactly what it sounds like. It's a jumbling of words. But followed closely by logorrhea, which sounds like diarrhea, which makes perfect sense. So it's basically just mouth diarrhea, right? Like people are just rapidly slurring and like spitting out words that may or may not have any like meaning. So people might engage in confabulation, which is making up fictitious details of past events to disguise their inability to remember. And this is important for us to think about too when we're in mental health, because a lot of the time how we see that interpreted by clinicians is saying that somebody is lying, attention seeking, manipulating, which, oftentimes with somebody with a dementia-related disease, it's as simple as they can't remember and they're embarrassed to say that they can't remember. So it's easier for them to make up fictitious details. Or they feel this conversation happening and it's going really well and they want to contribute to it, but they don't know how because they don't have memory to fill in those details themselves. So they're making them up because they want to keep engaging with you. You might see cataclysmic reactions, so those big freakouts over something really simple, like hearing that they're having meatloaf for lunch. That can turn into like a tearful kind of surreptitious event. Neologism, so that's invention of words to which meaning is attached. So a cool one that I heard one time was somebody who couldn't remember the name for astronaut, so they called it a space zoomer, which makes so much sense. That's perfect to me. You might hear echopraxia, so that's kind of like repeating. It's like a little bit of repeating going on. And then in the late stages, you'll see just more people kind of like withdrawing inward. So mutism, yelling or moaning, which can be motivated by just that passing air over their vocal cords, like without realizing what's going on, or it can be indicating like a physical kind of issue that's going on with them, pain, something like that. Or it might just be that they want to speak and they can't. So a lot of different things that can motivate that. And then I always mispronounce these. Echolocalia. Wow, I think I did that. And palilalia. Sounds like Hawaiian flowers to me. I don't know. But basically, these are just repetition of words. So either it's repetition of another person's words or repetition of their own words. So like one that I actually saw a few weeks ago was somebody who was just kind of stuck in a loop of realizing something, and they were just going, "Oh, right. Oh, right. Oh, right." So they were just repeating that for like 4 hours. And honestly, it seemed like a good place to be stuck. So what do we think about when we think about Alzheimer's disease? Generally, we think about challenging behaviors. So challenging behaviors are basically the most distressing symptom of Alzheimer's disease, specifically in the early stages. And they can include agitation, changes in motor behavior, anxiety, irritability, depression, apathy, disinhibition, delusions, hallucinations, sleep, or appetite changes. And almost all people living with dementia experience at least one at some point. I don't really understand this percentage, like where they got 97%, because I feel like it should be 100% because these kind of behaviors are like a hallmark characteristic that's looked for a diagnosis. But I guess I don't understand research, so there's that too. So pharmacological interventions are really limited for people with Alzheimer's related diseases. Doctors don't like giving out benzodiazepines because they increase fall risks. But generally speaking, outside of the mental health field, you should not see antipsychotics being used in people with dementia related diseases. And that's because they actually increase the chances of death. There's a black box warning, what's called a black box warning on antipsychotic medications, and that's because they've been very strongly linked to an increase in death for people with dementia-related diseases. So unless somebody, has a pre-existing mental illness or there's some kind of like really serious behavioral concern, you generally won't see that. And actually in New York State, in nursing homes, there are legal standards on what percentage of people can be on antipsychotics in a senior living facility, which causes a lot of complication when you're trying to discharge people with mental illness and dementia-related diseases. Places don't want to take them. All right. So when we're thinking about challenging behavior, we always want to apply the unmet needs model to that, because it really is true. Challenging behavior is always the sign of an unmet need. And we might not know what that unmet need is, and we might speculate on what it is, but ultimately, like, it's our job as professionals to investigate that. All right. So we're talking about challenging behavior. We're talking about cellular death in the brain. And so we can't expect people to regain their brain functioning. It's literally not going to happen. Their brain is dying. When we looked at the picture of the atrophied brain of somebody with Alzheimer's, we cannot regenerate their brain. It will not happen. We know that pharmacological interventions are severely limited. So that's likely not really going to happen for people either. So what can we do? We can change our approach, right? We can be careful. Are we engaging in power struggles? Are we having realistic expectations for the person that we're interacting with? How are we interacting with them? Are we baby talking them? Are we being short? Are we being domineering with them? Are we experiencing our own anxiety around interactions? And this is huge. Older adults are extremely triggering for people, because I think for a lot of people, they see their own aging process and their own mortality in the person that they're working with. And that can be really scary for people. Caregivers might be succumbing to anticipatory grief. You might have been working with a client for a long amount of time and you're seeing their decline, and like, you are grieving that. You have a relationship with that person. And something that we see a lot of practitioners engage in, and I've been guilty of it myself, is mistaking something that's annoying for being unsafe. And so we're rushing into a situation with a response that might not be appropriate because we are annoyed. So what is reality orientation? It used to be the gold standard for senior living. So basically, what that meant for us as healthcare providers is that we wanted to bring somebody back to reality. And it was initially developed for veterans with PTSD, and it's really been the gold standard. And you'll still see a lot of places really stick to their guns with this, which doesn't make any sense to me at all, because I have never run into any kind of nonprofit or organization that specialized in elder care that still backs up reality orientation. It's just not best practice anymore. But it's basically the idea that you're orienting somebody to your own reality. So what we see with that is, like, somebody standing at the door and they're 85 years old. You ask them what they're doing and they say, I'm waiting for my mom to come pick me up. We're using the reality orientation and we're trying to pull that person back to our reality. What we would say to that is, your mom's not coming. She died years ago. Let's go to lunch. Well, what does that do for the person that you just told that to? I mean, they really think their mom is coming. You not only just told them that their mom's not coming, but that their mom is dead. They're probably experiencing all that grief and loss that they already went through losing their mom years ago all over again. So, I mean, yeah, it's sticky, right? So why does it suck? It's not often done with care. And it steamrolls the autonomy of the affected individual, because basically what you're saying is that your reality isn't true and my reality is the standard. So you need to get on my level. It's not meeting people where they're at. And it leaves everybody frustrated. Something that people working with people with dementia-related diseases should remember is that people might not always remember specifically what you said, but they will almost always remember how you made them feel. And you can see that when you work in elder care. You can see the staff walk onto the unit that don't interact in a therapeutic way, and you can viscerally feel the adults with dementia's reaction to that. And they might not remember the person's name, and they might not remember how they know them, but they know that they don't like them. And you can see the opposite too. The person who is engaging with somebody and meeting them where they're at, they're gonna smile. They're gonna smile when you walk in the room, and they might not even know who you are. So validation therapy is a different kind of approach for how we work with people with dementia-related diseases, right? It's about working with somebody, focusing on what they still have, what strengths they still have.
We have arrived at Act 2 of our program, Act 2, Rainy Days and Mondays. According to the Alzheimer's Association, every 67 seconds, somebody in the United States develops the disease. We're at this point with Alzheimer's where almost everybody has had some sort of personal experience with the disease through a spouse or a parent or a friend. And because we've had that direct experience, we all know how scary Alzheimer's can be. The thing you hear a lot is the emotional toll of taking care of parents and spouses, and you hear about the cost. But there's this other more basic challenge. People don't talk about this as much, but it must be a problem that everyone close to the disease struggles with, and that is, what are we supposed to talk about with our relatives who have Alzheimer's? What do we talk about? The same stuff we always have?
Did they tell you Jenny and Joe are moving to Florida?
No.
Yep. Joe got a promotion, and they're going to go to Florida.
Sharon Stobie is sitting on the back porch of her sister's home with her mom, Virginia.
Something like that.
They were in Florida.
Super good.
Sharon says to her mom, "You were in Florida."
Where were you?
Let me think. I can't remember.
Do you remember who you were with?
This is a little off mic. She says, "Do you remember who you were with?"
I was with Betty.
Yeah.
Oh, dear.
And you met somebody there.
Monday, Tuesday, Wednesday, Thursday, Friday.
Met somebody special there.
Dad. Dad is the answer Sharon's searching for. My father, your husband. Sharon didn't go into this conversation trying to play some, memory game with her mom. She just kind of fell into that. And it's easy to see how, right? You love your mom. You want to spend time with your mom. What are you going to talk about, right? Shared memories are out. Mutual loved ones are not remembered. Even current news, like joyful news, does not necessarily create a connection. Right before they sat down on the porch, Sharon's sister showed Virginia a picture of her 2-week-old granddaughter and said, "Mom, look how beautiful, your great-granddaughter." And Virginia looked at the picture and said, "Oh, no," for no clear reason at all. Sharon has a sister named Karen, and Sharon's the oldest, Karen's the youngest. Virginia, the mom, was with Karen. And one of our producers, Chana Jaffe-Walt, got interested in this experiment that Karen has been trying in their family. Karen's been on a search for a new way to talk to her mom, looking, for some magic words to say to her mom as her mom is losing her memory, words that will keep them connected. And recently she developed a plan, a fully formed theory of social interaction for the dementia landscape. She's got rules, she's got best practices, it's a whole thing, and she thinks it can work. Here's Chana Jaffe-Walt to explain.
Karen didn't have the plan in place when her mom first moved in with her, but she has wanted a plan from day one. Day one, there was just this constant stream of questions that never had definitive answers. Like, can I leave my mom at home alone? Or what am I supposed to do when she wakes up at 2 a.m. and starts getting dressed? What about when she wants another bowl of ice cream? And I remind her that she has diabetes, but she forgets that she has diabetes. See, Karen is a person who likes structure. The lawless, do-it-yourself nature of home dementia care never sat well with her. Karen would do what she thought was right, take the ice cream away, and her mom would lose it, scream at her. This is a woman who never had a cruel word to say about anyone, who considered shoot a swear word. She would look right into Karen's eyes and say, "You're a supreme You know that?"
I had this moment where I Googled the rules of caregiving for someone with Alzheimer's. And I thought, I wondered for some reason if they were even out there, if there was some. And when I read one of them that said literally step into their world, I went, bam.
Step into their world was a familiar phrase to Karen from the many nights she'd spent doing improv comedy. She and her husband are actors. Step into their world is a mantra in improv. You walk on stage, another actor says something, and you step into their world, whatever world they've just created. You don't ever say no. You don't question their premise. You just say yes, and...
I didn't even see it. I didn't see the whole parallels of improv and Alzheimer's. And when I did, it was just so obvious. It's a whole yes and world.
If all you've got is yes and, you can't say things like, "But you don't even like pickles," or "You don't have a sister, Mom." You don't tell someone they're wrong, which Karen says is exactly what you always want to do. Like when her mom says she wants to go home, the most natural response is,
"Oh, but this is your home now, Virginia. Come, let me show you your room." But this woman is looking at you saying, "I want to go home," and you're telling her she lives here? So now you're telling her she's a liar? So you're going to see her little veins start popping out in her neck and her little fists. But if you look at her and you say, she says, "I want to go home." "Yes, and tell me about your home."
Now she's not a liar anymore. Karen felt like she'd discovered an instruction manual. Here was a way into a relationship with her mom if she just followed some basic rules of engagement, rules she conveniently already knew. And so did her husband, Mundy, who was glad to have some guidelines for how to relate to this new roommate. It's like improv, Karen explained. You love improv.
That's what I was like, okay, that's cool. I know how to do that, and that's what I'll do.
For Karen, using the tools of improv meant when her mom, Virginia, sees monkeys out the window, don't correct her. But Mundy took the whole thing to the next level. When Virginia sees monkeys, Mundy sees them too. He told me, "Oh yeah, just the last time that happened, I said..."
It's pretty early in the season for monkeys. Didn't even know actually that they were here in North Carolina. "Oh, there's not a lot of them, but they're pretty busy now." Well, if you see one again, we should try and capture it, because that would be a blast to have in the house. You can't keep monkeys in the house. Well, you just have to train them right and give them pants, because if they don't have pants, I mean, that's just a barbarian's monkey. We can't have monkeys in the house. All right, so I guess you're making up a rule that we can't have monkeys in the house. Yes, I am, but at some point, there's something in her mind is going, we're not being serious now about monkeys in the house.
And it's fun for her.
And it's fun for her, yeah. Yeah, she's definitely having a good time.
For years, the staff in nursing homes and dementia care experts advised families to keep your loved ones with you, mentally speaking. Remind them who they are, where they're from, show them pictures of your family. Hang orientation boards everywhere that say, "Today is August 15th. The weather is overcast. The president is Barack Obama." But recently, the experts have changed course. And in the last decade or so, things like validation therapy are what's in. Caregivers are encouraged to listen, respond, try to live in their reality instead of trying to pull them over into yours. Basically, exactly what Karen and Mundy stumbled into on their own. Most people find it pretty challenging to interact in this way. But for Mundy and Karen, it's not hard. Mundy does it all the time, without thinking.
How are you doing?
I'm okay,
Yeah?
I think.
What a day.
It's strange that when you get up the mountain, it's much lighter in the sky. I'm very noticeable
You are very noticeable.
of things.
I've noticed you.
Don't tell
I've-
Melanie.
I've noticed you before.
Virginia points to the family terrier Gus, tearing around the backyard, digging holes.
He's digging like for his life.
Gus is busy working on his caverns. He's starting a coal mine, so he's going to get it started, and you're going to finish it up, right?
I am
The coal mine.
the coal mine. I never worked in a coal mine.
I know.
Mundy says, "But I need you to now. I need your help finishing up the mine. Got to get out there and find some coals so we can pay off these bills." Virginia gleefully refuses. So Mundy says, "Oh well, we'll have to shut down the whole operation then."
All right, Gus. No, she doesn't want to go in, man.
Stop digging!
All right, stop digging.
Stop digging.
Gus!
No digging. No.
This is a family all doing something together, sharing the same reality. The reality of closing down the coal mine in the backyard. When you're with your family, your parents, or uncles, say Thanksgiving, think about how much time you spend collectively recalling things. Remember when Mom laughed so hard the juice came out of her nose? Remember when Dad got in that crash? Or did I ever tell you how you potty trained yourself because you saw your brother doing it? It's nice to share memories. Makes you feel connected. But also, usually what you're actually doing in that moment with your family is boring. You're watching the game, eating chicken for dinner, again. It's fun to recall the more dramatic moments you've shared because they are not boring. They're not boring experiences you've had together. Virginia no longer has those memories to call on. She spends a lot of her day sitting on a porch, which can't be all that interesting. But when Monday is with her, there's literally drama. They're dismantling a mine. It's the most animated and happy. I see Virginia all day.
Yeah, the coal mine
He'll
plan's
be here in
over.
a few seconds. There he is.
The coal mine plan's over. No more Gus Caverns.
All right, so I really, really love that radio segment because I feel like, yeah, it's just the most accurate description of what good validation therapy is like. Like, there's so many parts in that are wonderful, specifically when, like, Virginia is talking about how she wants to go home, because that's such a common thing we hear from people because they're so caught off guard at all times about being in a facility. Like, if you think about what that's like to have memory loss and then to just be every moment thinking, like, where am I? What's going on here? Like, what am I doing? And then just never having, like, resolution to that. It must be so scary for people. And so, of course, it makes perfect sense that they would be, like, voicing that all the time. Like, I want to go home. This is unfamiliar. This is scary. I don't feel safe. What's happening? Who are these people? And that's just kind of coming out as, like, I want to go home. And how many times have we heard working with older adults, people say, like, no, this is your home. And whether they say it in a nice way, you know, or in a less than nice way, like, the message is still the same, that their anxiety isn't going to be alleviated in any way. In fact, now it's, like, increased because they're kind of grappling with the fact that they don't even know where their home is anymore. Like, that's horrific, really. So, like, that moment when they're talking about, like, how to shift the focus of that conversation into, tell me about your home, right? Like, that's so meaningful because now you just took a conversation where a person is questioning everything about their life and turned it into an opportunity for them to talk about, like, a good part of their life and to share with you and to build something with you about that. And that's kind of the foundation of validation therapy. It's just, instead of trying to pull people to where you are because you're assuming that where you are is correct, it's just going wherever that person needs to go in that moment in order to feel better. So it's kind of moving your perception to them. So it's basically just a way of demonstrating to the client that their feelings, thoughts, and opinions are acknowledged and respected by the caregiver. And using a combination of validation and reminisce can help confuse clients experience joy from their earlier life and can contribute to their overall quality of life. Because again, we're not gonna bring somebody's brain functioning back. We're not gonna repair their cells. That's not a realistic thing to expect somebody with a dementia disease to be able to do. So what is validation therapy? It was developed by Naomi Field in the 60s and 70s, and she was pretty interesting. I guess her mother was like a social worker at a senior living facility, and her father was like an administrator. So she kind of grew up surrounded by older adults, and she just developed this intervention. And you know, I'd like to think that people around her were kind of already innately doing it, but she put the oomph behind it and got her, like, you know, social work degree and wrote about it and researched it and made it like an actual practice. And it's just acknowledging and validating people's emotions. And a big part of it too is it's cultivating pleasure in difficult situations. Again, like, you're interacting with somebody who's experiencing a lot of anxiety and grief and all kinds of negative emotions, and you're minimizing that frustration by just making peace with where they're at and focusing on what they need. So how do we use it, right? It's important to think about how we're using validation therapy, and it's especially kind of spicy in mental health because we have this, idea that we can change people's fixed illusions and that we can orient people into reality. And I don't know personally how I feel about that, to be completely honest. It's challenging because so much of people's mental health is motivated by kind of their chemical standing, like what medications they're on and where they're at in their disease process and what they have specifically. But again, like, working with older adults, this is a very different situation. So just consider the client that you're working with, consider your relationship to them. Again, just go back, like, what does this person need right now? And how am I going to meet them where they're at? We talked a little bit about like caregiver anxiety and how caregivers can be anxious and have a lot of negative emotions like going into a conversation with somebody with a dementia related disease. So like be mindful of that, honor that, right? Check in with yourself. How is my body feeling right now? Like, where am I at mentally? Am I in a good place to be interacting with this person? And if I'm not, like, what do I need to do to get myself to that place? So how do we initiate? We want to approach the individual from the front. People with dementia-related diseases are actually having a lot of changes, not only in their brain, but in their eye cells. And so they have a hard time interpreting peripheral imaging. So like people will kind of only be able to see what specifically is in front of them. They also lose a lot of their color perception. So it can be hard if you're wearing the same color as whatever is in the background. It can be hard for them to differentiate like who you are from the background. If the environment is very stimulating, that can make it challenging for them too. So we want to try to approach from the front, and we want to keep our body language relaxed. This is a disease where people are having a lot of issue with verbal processing. So we want to be really conscientious about our nonverbal communication and like how we're presenting to people. And that means you need to fix your face. Take a minute to fix your face. If you have, the resting face, like be aware of that. Maybe the mask is helping you in that way. For most of us, it's a hindrance. So we need to make sure that we're communicating with our eyes and we're putting a lot of kindness into our eyes, because that's what people are going to be looking at when they're interacting with us. Unless there's a safety issue, try to get on that person's level and get a little bit closer to them. That's going to help them see who you are. Always introduce yourself. Always. Even if you have been working with this person regularly, every day for years, it's just good practice to walk in the room and say, "Hi, it's Hannah. I'm here for your session." That just takes all of the question out of it, and it can put them right at ease. Call them by their preferred name. This is really, really important. I worked with an older adult at a nursing home, and his name is Salvatore. So I always called him Sal, like always. And we had a good relationship. It wasn't anything super special, but we worked well together. And his daughter came for a visit after about a year of working with him, and she was calling him Sam. And I asked her, like, what's up with that? And she was like, yeah, when he immigrated to the United States, like, he wanted to use his new name, so he started going by Sam instead of Sal. And once I started calling him Sam, it was like he was a whole different person. It was entirely different, like, because I went from being somebody who knew him to somebody who was familiar with him. So when I addressed him by the name that he preferred, it was like I was a friend. And that was like, it made our relationship so much better. So taking the time to find out, like, what pronouns does the person use? Do they have any nicknames that they like? Are they more formal? Do they want to be called, Mr., Ms., whatever? And when you're initiating, just like lock in and get ready for the ride, because you don't know where you're going in that conversation. And sometimes it can be fast, and sometimes you can go really weird places. So you want to focus on the feeling when you're talking to somebody, right? So use extremes. What do you miss the most about your mother? What was the best thing about your house? Where was the most comfortable spot in your home, right? Use those extremes. Reminisce with them. Focus on that memory. Like, if they're asking when is lunch, ask them if they like to cook, right? If they did, like, ask them about their favorite recipes. Share something personal about yourself. I think for other clinicians, sometimes it seems like there's more me and them. And, there's a time and a place for that. But we're kind of in a cool place as recreation therapists, because we get to know people through their hobbies. And oftentimes there is overlap. That's one of the things that makes the therapeutic relationships, successful. So if they're sharing a band that they liked or something, it's okay to say, like, hey, you like this? I really like this thing. And that's going to be something that you can build your relationship and rapport off of. Match and share the emotion, right? So if they're upset, you don't want to come in and be all like, sweetheart, da, 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 trying to like be, cheering them up. Let them be upset. That's fine. Match their emotion. That sounds really hard. You miss your mother? That sounds really hard. I miss my mother sometimes too. That's okay to say that. and focus on sense-based memories, right? So, what kind of clothes did your mother wear, right? Like, what was her favorite outfit? Focus on more sensory related things so that they can kind of have an easier way to recall those memories. So if you want to use distraction, right? So we're distracting. Something that can work really well is prompting for an environmental change. So they're waiting for their mother at the front door and, their mother's not coming to pick them up. You know that. Can you distract them and redirect them into something else, right? So, oh, I'm not sure. I haven't heard if she's coming or not. Do you want to have some lunch while you wait for her? Can you move with them, right? We had a client here at the hospital who used to just bang on the doors to leave. And one thing that was really effective with them is if I slid in between them and the door and started going 1, 2, cha-cha-cha, 2, 2, cha-cha-cha. And then I could literally cha-cha-cha them all the way to the dining room and spin them in a chair for lunch. It worked every time. Another time we had to help get a patient into a treatment room for a medical treatment, and we could not verbally prompt the patient to move. So we started a conga line. And it worked really, really well. They literally conga lined with me and a few other direct care staff right into the treatment room and sat right down and got their treatment. It worked perfectly. Move the conversation to an environmental focus. If you're going to distract them too, you might be able to say like, wow, it's really sunny outside. It's such a beautiful day. Let's go check out the window. Or if there's something on the wall, right? You may be able to reorient them to that. We're just kind of moving. We're moving. So our redirection, we just noted earlier, right? So it's moving into another task. And so this is kind of where our yes and comes in too. So again, that might be like if somebody is waiting, at the front door, we're not going to say like their mom's not coming. We're going to say, sure, maybe she is coming and your lunch is ready. And we're doing, this activity in the living room. Do you want to come? Right? So we're not discounting them. We're validating the emotion, but then we're moving into something else. So I wanted to include this. This is the broaden and build theory. And it's funny. It's a positive psychology theory, which normally I hate positive psychology. And it makes me feel like I'm going to vomit in my mouth because I just think it's so gross to like work with somebody who's upset and then to try to make them be happy and to have that somehow be like the benchmark for how good your therapy is. And I don't know if that puts me at odds with a lot of other recreation therapists, but that's how I feel about it. But I love this idea of positive psychology turned around and applied to us as caregivers. So instead of trying to make our client be happy, to focus on how we can be happy for our clients in order to improve that relationship. So this is kind of a cool theory that was written by Barbara Fredrickson. She wrote a lot of studies and books about how to use love in your therapeutic practice. So basically what she's saying is that if you come into the relationship with positive emotions, right? Joy, love, contentment, interest, happiness, then that's going to expand the inventory of the thoughts and actions between you and your client. And that's going to build your physical, mental, and social resources for your client and build your relationship. And then that's going to transform both your client and your relationship through personal growth and positive emotions. So kind of interesting. I feel like love is like also kind of a spicy topic when we're talking about therapeutic relationships, but I don't really think it necessarily has to be. She has this nice quote in here too. Love is a momentary upwelling of 3 tightly interwoven events: a sharing of one or more positive emotions between you and another, a synchrony between you and the other person's biochemistry and behaviors, and third, a reflective motive to invest in each other's well-being that brings mutual care. And that's on therapeutic rapport, honey. So just some general communication tips too, like we want to stay respectful when we're talking to somebody and not use baby talk. And that can be hard because for a lot of people, how they relate to older adults is by imagining them as being children, and there certainly are some similarities, but we always want to stay respectful and remember that this is like an adult. We offer choices to the person, and if choices are overwhelming, can we modify and simplify? Even if you ask about one thing, you're still asking, that's still a choice. So instead of green shirt or red shirt? If that's overwhelming, can we just ask, do you want to wear your red shirt? Because it's giving them the opportunity to say no. How can we simplify our language, and how can we stay familiar, using somebody's preferred name? If it's appropriate, are we touching the person to prompt them, right? Like, can we touch on the shoulder? Can we touch on the hand? That can help focus people. How can we slow down? And how can we let it slide? I gave a presentation at this conference a few years ago about challenging behaviors in dementia care. And I remember one of the participants had a lot of questions because they had a client who was continuously calling them fat. And it was really, really upsetting that person. And they have every right to be upset. That's really, really challenging to be verbally harassed when you do your job. But a lot of the conversation was focused on how to make that person stop calling this therapist fat. And that might not be something that we can ever do. And that's really hard. We can try to address the unmet need that's there, and we can try to address the behavior, but at a certain point, we have to be able to step back and let things slide. And also to be able to say, like, maybe I'm not the right person to work with this individual. And if there's options there, to explore that. And we want to be able to enjoy, right? Like, we're going to be going on an adventure, like an imaginative adventure with this person. So we want to be able to enjoy that. So some environmental considerations, turn off background noise. We want to turn the TV off when we're talking. We want to try to keep the space quiet. Overhead announcements to a minimum, right? We want to consider the time of day and the lighting. A lot of people with Alzheimer's and dementia-related diseases, they sundown. And we don't really know why people sundown. Some people think it's related to people's circadian rhythm. Some people think it's related to just like feelings of anxiety and uncertainty about somebody looking out the window and seeing it being dark out and not knowing how to interpret that. We know that people's like biological clocks just get off when they have a dementia-related disease. So consider when you're doing your intervention and what kind of intervention it is. Maybe a really physically active program isn't the best thing to be doing around shift change at 4 p.m. So how can we keep things calm? And can we consider tactile interventions? There are a lot of different ways to do this. Some people use like stress balls or kinetic sand or something with people that they're working with. Those little like twiddle muffs, I think they're called, are really popular. So those are like those little knitted things that have little buttons and zippers so that people can kind of fidget with them. Other people like rocking a baby doll. That's really therapeutic, and just like that movement, like they really benefit from that, and it keeps things calm, right? So when we're working with somebody with dementia too, we want to make sure we're taking time for ourselves. Like, it's very, very, very challenging. And people that say it's not that challenging, if they really believe that, I love that for them. And I hope that I can someday develop that mindset myself. But I mean, I see it definitely as something that's really challenging, even though it's something I really enjoy, but it is really difficult. So take care of yourself, whatever you need to do, to make that work. And if that means you have a friend that you're talking to about things, while respecting confidentiality, of course, or a therapist. Are you taking care of your own health? Are you taking breaks, right? Like I mentioned, the crying in the recreation closet, but that kind of thing is like essential. If you need a break to fix your face, take the break. Like nothing is worth those 2 minutes. You can always make time for that if you need it, if it's going to be the difference between you having a good program or a good intervention and you not. So make sure you're making that space for yourself. And always reach out to the Alzheimer's Association. They're like super, super wonderful. There's tons of resources available. They have like a 24-hour call line, so you can call with questions at any time. They can connect you with resources. They have a huge educational database. A lot of the resources for this presentation came from the Alzheimer's Association educational database. They have a lot of community educators that will come to your facility and do trainings, or will provide materials for you to do your own trainings. So really take advantage of that. They're really great. You can also hit me up. I don't like doing my documentation. And so if you email or call me with questions, I would much rather help you with that than do my documentation. So if you have any questions at all, please, please, please let me know so I don't have to do my documentation. And if my boss is listening to this, I'm really sorry. I swear I'm getting it done on time, but don't check it before the survey. Or maybe do check it before the survey. I don't know. But you can always hit me up for questions. If you want a copy of this presentation, you can also hit me up. I will send you a copy. You can hack it, shop it, do whatever you want to it, use it in your facility. It's totally open source. So feel free to just shoot me an email and I can send it back to you. I want to give a big thank out to wow, it's like a shout out and a thank you squished together. I want to say thank you to Nystro for holding this conference virtually because it's hard enough to plan a conference in person, and I don't know how you guys have been able to do it virtually because it seems like really a huge amount of work. So thank you for doing that. Big thanks to Perry Crocker for letting me use his microphone to record this, so we have really good audio and you guys can hear all the rustling in the background in my dry mouth while I'm talking. Thanks to the staff here at RBC who will let me facilitate this for them because I cannot talk into a microphone in a room by myself, which I'm going to be unpacking in therapy for years to come. And I want to say thanks to all the people with dementia who trusted me to care for them and gave me like some of the best moments and memories that I think I'll ever have. So thank you for that. And then I got some references. So again, if you want a copy of this presentation and you want to get into the references, that's all you can totally do that on your own time. So that's it. That's all for me.